Hello, my name's Allison Bailey, and welcome to tonight's CardioCore lecture series. I'm so excited to be here and be a part of this talk on residual risk of cardiovascular disease. Our esteemed speaker is Dr. Vijay Nambi. Dr. Nambi's clinical background includes training in internal medicine and cardiology with a focus on prevention and non-invasive cardiology, as well as vascular medicine with expertise in ultrasound-based imaging. He currently serves as the program director of the Lipids and Lipoprotein Fellowship at Baylor College of Medicine and is a staff cardiologist at the Michael E. DeBakey Veterans Affairs Hospital in Houston, Texas. He's locally and nationally known as an expert in lipidology and cardiovascular prevention. He has more than 90 publications and has been an invited speaker at several national conferences. Let's welcome Dr. Vijay Nambi to the show.
A very good evening to one and all, and I thank the ASPC for this opportunity to present to you about residual risk of cardiovascular disease. My name is Vijay Nambi, and I'm a professor in cardiology at Baylor College of Medicine and a staff cardiologist at the Michael E. DeBakey Veterans Affairs Hospital. These are the disclosures related to my talk. Most of them are not related to past studies and grants and other disclosures that may be relevant to this talk. The views are my own, and they do not represent those of my institutions, necessarily represent those of my institutions. So I want to acknowledge people who've been helpful with their slides and, to get this talk up and about for you. So if you think about this concept of what we're planning on discussing here, we're planning on talking about what this concept of residual risk means. Now, what it is, where are we with that? What can we do in the future? And that's kind of what we're hoping to have a conversation about over the next hour or so. So if you think about residual risk, it can be thought of as the risk that remains when you've had optimal treatment of current risk factors of the disease, right? But some of it has to extend because sometimes we may not have optimal treatment, and that, in other words, the risk factor may not be optimally treated, and that may manifest or be presented as a residual risk too. Now, this residual risk, some of it may be, more intense treatment of existing risk factors. Sometimes it can be undiscovered risk factors, or sometimes it can be from risk factors we thought were not modifiable in the past, but now getting to be modifiable. And of course, there are non-modifiable risk factors like your age, right? At least at this point of time, it's non-modifiable. So, this is something that we can't do anything about. So all of that put together constitutes the residual risk of cardiovascular disease. And we'll kind of delve into what this may be and how this looks and where we are at this point of time. So if one looks at our current state of the art, we know there are classic risk factors, your blood pressure, diabetes, cholesterol, smoking, obesity, things like that. And in this study, what we did was we worked with a big cohort of, several cohorts across the globe. And this resulted in almost and we looked at certain risk factors, right? The 5 modifiable risk factors: body mass index, systolic blood pressure, non-HDL cholesterol, current smoking, and diabetes, and looked at 2 specific outcomes: cardiovascular disease and all-cause mortality. For this, there were several cohorts, as I mentioned, that contributed, and there were almost about 1.5 million, 1.5 million individuals from different parts around the globe. Now, interestingly, when we looked at these risk factors and their association with events, sure enough, as these risk factors went up, they were clearly associated with cardiovascular disease, less so with mortality, but the overall, with cardiovascular disease, you can see that there was as these, many of these risk factors went up, the cardiovascular disease, risk went up. And that's kind of well known to us. This is how we, what the basis of why we treat these risk factors for reducing cardiovascular events. But interestingly, when you start looking at it, there is some differences across the globe, across the different continents. But interestingly, when you look at the actual residual risk, in other words, what's the risk that remains once you've accounted for these, you will see on the top, almost 50% of, cardiovascular disease could not be explained by these traditional risk factors. That potentially is the residual risk that remains. Now, granted, these studies spanned several decades. It spanned several continents. So the way we collected risk factors, when we collected risk factors, how we treated it at that point in time, all could have changed and have been changing over the last decades. So it may not be a perfect representation, but suffices to say there's a good amount of risk that remains after we take care of these traditional risk factors as we would. Now, if you consider our guidelines, the context of the main concept of the main fulcrum of our guidelines is using these risk prediction tools. We ask ourselves, what's the LDL cholesterol? If it's high, we say treat. If it's not, do you have diabetes? If that's there, we say treat. And then if not, we estimate our 10-year risk. And based on the 10-year risk, we decide, who should and who, may not get benefited from intensively treating cholesterol or now even blood pressure. Now, in this, we've also come to recognize that not everybody is built the same and not everybody's risk is the same. There may be two individuals with diabetes with different risk, overall estimated risk and observed risk too. So although these risk factors have formed the crux of our risk prediction equation, we understand that these were developed because this was what was identified at that point in time in the epidemiological studies, and they've been a good, very strong base for us to build our risk prediction models. But most of these other risk factors, when we are, or these markers, when we add them, may improve the risk a little bit, but not enough to implement on a large scale basis as yet. And as a result of it, in the previous guidelines onwards, they started asking us to focus on these risk enhancers. In other words, this tells you a starting point of a story, but how we have to think that this is not perfect. And this, in fact, if you look at it, is manifested in several things where we either overestimate risk or sometimes we underestimate risk. You can overestimate risk in individuals with high socioeconomic status and engaged patients. On the other hand, you can underestimate risk in individuals with sometimes, low socioeconomic status, HIV, inflammatory disease. We also know there are some ethnicities more prone to cardiovascular disease and so on and so forth. The point being, our risk tools are great for a general population, but there are going to be individuals you under or over-identify risk as far as that goes. So given these, we in the guidelines have been taught to look at these risk enhancers. So what are these risk enhancers? If you look at the overall population, overall global risk enhancers, these would be things like family history, or you have a very high LDL cholesterol that's persistent, say maybe above 160, metabolic syndrome, chronic kidney disease, premature menopause, preeclampsia, high-risk ethnicity such as South Asians, increased ApoB, or if measured, elevated CRP, elevated LPA, an ankle brachial index. The point being, these are all things we know that slightly heightened risk, and these are what your risk enhancers are, which we can factor in our discussion with our patient. Now, not only are there overall global risk enhancers, but there are also specific risk enhancers. For example, among individuals with diabetes. Among individuals with diabetes, longer duration, or if you have end organ injury, say you have albuminuria or low eGFR manifesting kidney injury, or if you have retinopathy or neuropathy or an ankle brachial index less than 0.9, these are all risk enhancers. In other words, they increase the risk of an individual with diabetes for cardiovascular disease. Same way, women-specific risk factors have been identified, basically dealing with the length of their lifespan from early menarche to use of contraceptives to spontaneous pregnancy loss, pregnancy-related things, spontaneous, preeclampsia or hypertension, gestational diabetes. All of these are risk enhancers. And then premature menopause or premature ovarian failure can also enhance a woman's risk for cardiovascular disease. And these are all been recognized. Same way, cancer and cancer chemotherapy, those things can also increase their risk. Similarly, when we look at individuals with existing cardiovascular disease, there are higher risk individuals, as can be seen here. Patients who've had an acute coronary syndrome or multiple episodes are more likely to have a higher risk. If you have, poorly controlled diabetes, very high cholesterol, CKD, all of these things increase your risk. The point again being, you have to be able to identify the higher risk individual, even if your risk score doesn't tell you that. And that's what these risk enhancers are doing. Why do we need to do that? So that we can start understanding, appreciating, and identifying that residual risk to treat them. Now, if you look at these, because of this, there was a recent paper that looked at these potential, what they call SMRFs, or standard modifiable risk factors, and the non-SMRFs. In other words, you have to start recognizing these. And in that format, they talked about the different SMRFs that can be there, from your pollution, exposure to toxic fumes and things like that, to mental health status, depression, exposure to sometimes your genes can contribute towards it, inflammation, lack lack of exercise, all of these things, sleep health, all of these things can slowly contribute. And these are your, non-SMRFs, so not the standard modifiable risk factors, but the non-SMRFs that can increase your risk. So the reason for focus on all of these things is for us to start recognizing as clinicians that there are things that can increase your risk, which we may or may not, be using in our traditional approaches in discussing with our patients. So we know that overall, lowering cholesterol reduces cardiovascular disease risk. And statins are the mainstay. And we've seen that across several studies in primary and secondary prevention, that statins reduce your risk. And it reduces your risk by about 20% or so for every millimole per liter, about 40 milligrams per deciliter reduction in your LDL cholesterol, you reduce your risk of major cardiovascular events. But important to note here is after this, in your statin studies, if you look at it, you can see that they did reduce the risk by 20-30%, which means there's a residual risk of almost 60 to 70%. Now, this is not to say that all your residual risk is cholesterol, but we're using cholesterol as a construct to say that that's the amount of risk that remains. Now, let's take it a step further and look at other studies and things like that. We say, okay, add on ezetimibe, that lowers your cholesterol further, right? Now, if you look at it, yes, it significantly lowered your cholesterol. Yes, it significantly reduced your events. But even in the treatment group here, ezetimibe plus simvastatin, there was a 32% event rate over the course of the next 7 years, which approximates to about 4% per year approximately, right? So that is the residual risk that remains. Okay, what about PCSK9 inhibitors? Similar story. If you look at it, almost 4 to 5% in the two big studies, alirocumab and evolocumab, which led to the approval. Icosapentethil, 17.2% over 5-year follow-up. Hypertension, SPRINT was about 1.65% per year in the intensively treated arm. Antithrombotic therapy, same way if you look at the diabetes medication, which we have a lot of hope and focus on, all of them do reduce the risk and they do a much better job. But even in them, you can see the risk remains 2 to 3 to 4% per year. In the patients who are treated intensively, they continue to have events. These are all what is that residual risk that we have to address further if we want to get a comprehensive approach towards further reducing the risk of cardiovascular disease or taking it away from the leading cause of death. So if you look at residual risk for atherosclerotic cardiovascular disease, this is a broad construct I use, which is looking at our traditional risk factors. How are we doing with that? Looking for novel risk factors, in other words, what's coming up in the future or what have we identified and can we combat that? There are going to be societal causes of residual risk, right? In other words, sometimes patients don't want to take medication, they don't believe in things, or they don't want to participate, being healthy and things like that, right? So those can also contribute to the residual risk. And clearly, we don't know everything there is as far as cardiovascular disease goes, and we are going to find newer and newer risk factors, and hopefully that will help combat some of the residual risk. There's always going to be some residual risk at the end of the day. That's bound to happen. But if we chip away at this, we will certainly have lesser and lesser risk as we go on over time. So overall, your residual risk may be reduced by better managing of existing risk factors or identifying these new risk factors and treating them. And these we could use other things to help. This risk may be identified by imaging, by biomarkers, and different ways to doing it. And that's what we'll hopefully review and here on. Now, this is the Jupiter study, which was a very successful study showing that 20 milligrams of rosuvastatin reduced the risk of cardiovascular disease in a primary prevention population. Now, there they looked for compliance of medication, pill counts, and this, that, and the other. Now, what you'll notice here is clearly in that red box over there, there were a group of almost 1 in 3 individuals, 35%, who had less than 40% or even no reduction in the LDL cholesterol. Remember, this is a high-intensity statin, and you know that high-intensity statin reduces your LDL cholesterol by 50%. Here you see 1/3 of them did not get that, right? Each of us are different, and how we metabolize and how we react to things are going to be different. So overall, if you look at it, even in these studies, it tells you there's a mean reduction of 50%, which means some people are going to get less and some people are going to get more reduction in LDL cholesterol. And you can see here, some people got more than 60% reduction. This is why, when the previous guidelines came out, when people started talking about high-intensity statin therapy, one of the messages that got away or got through wrong was that, there was a thought that you don't need to measure cholesterol anymore. That was never the intention of the people who wrote the guidelines. It's just that they recommended high-intensity statin therapy and to continue to monitor it, but that folks stopped monitoring the cholesterol itself. And as a result, we may have missed opportunities to get that cholesterol further down and reduce the risk itself. So variability in response can be one of them. Now, on the other hand, if you look at practices, we have a lot of tools, but this was a study we published about 10 years ago, which looked at about 256,000 participants of the Pinnacle registry with diabetes without documented CVD. We talk about diabetes as a high-risk group, but you can see here that facility level overall use of statin varied, and on an average, overall 55% of the patients are only on statin. And this is a high-risk group. And we clearly know that statins could help in this population, but only 55% were there. Now, we looked at the similar kind of thing in a VA population. And again, about, among patients with ASCVD, about 60-65% were there. These are clearly getting better. Some of it, I tell, maybe there was not documentation, maybe patients didn't want it, et cetera. But again, there are going to be a certain segment of population that was forgotten. In other words, they weren't started on these medications, and that's what this is highlighting. So this was an elegant study that looked at what physicians do, right? In this study, these were patients who were hospitalized with an acute coronary syndrome. And then there were a bunch of them already, about 27% on evidence-based therapy, and they were discharged. And there were some of them who at discharge, they had biomarker-directed therapy, and they were not on high-intensity statin therapy. Now look what happens after that. The yellow bar, 73% are discharged on low to moderate intensity statin therapy. And over the next year, 90% of the individuals had no change in their therapy, right? What happens in the hospital? We say, hey, we're going to deal with the acute issue. We're going to send the patient back to the primary care provider or the primary cardiologist to follow up. What happens there? They say, oh, he was in the hospital or she was in the hospital doing well right now, no changes in therapy. In other words, we've lost an opportunity, and this is inertia. Inertia at the hospital level where we, did not escalate. Maybe we started it, there may be reasons. And same way, inertia in the follow-up where we had an opportunity to interact with the patient and increase the medications, but this did not happen. So this is that clinical inertia that's there, which we have to address at several levels. Among ourselves, among our teams, we have to do that, but also clinician and patient education, trying to tell them why it's important to get this, intensive treatment, because this does reduce your residual risk. And there are tools that are being, system approaches and things like that that are being considered for the same thing. So the other question we have is, okay, this is all LDL cholesterol centric, but what if you use a better version of it, right? And this is where the potential of non-HDL cholesterol and apolipoprotein B comes in. Now, LDL cholesterol is the front and center, and that's what we use, and it continues to be our primary target of therapy. But remember, all atherogenic particles will have an ApoB. And a non-HDL cholesterol, which is just total cholesterol minus HDL cholesterol, is a good surrogate for ApoB. It correlates highly well. But again, ApoB would be the best marker of all atherogenic particle. So one question is, what if we looked at ApoB itself or non-HDL cholesterol? And in this study, they looked at ApoB and non-HDL cholesterol and trying to identify that residual risk. And here you look at all-cause mortality. And the population was divided as less than median and above median. Now, if you had less than median ApoB and LDL cholesterol, that was the reference range. What you see here clearly is if there's discordance, if ApoB was high, you did worse relative to the LDL cholesterol. And if both were high, ApoB and LDL cholesterol, you did, again, worse. But point being, ApoB was better at identifying those individuals who were going to do worse. That was the same with non-HDL cholesterol. And when you looked at non-HDL cholesterol and ApoB, overall, ApoB seemed to do well. This is for all-cause mortality, and a similar story, came up for MI, where overall ApoB was better at that, and non-HDL cholesterol was better than LDL cholesterol itself. So again, in our patients, when we're treating them, perhaps once we get the LDL cholesterol to where we want to, thinking about these kind of things to see if we can further intensify their treatment or make it better is something that we all need to consider. Now, what about other things such as triglycerides and triglyceride-rich lipoproteins, and their remnants have been shown, very nicely to be associated with risk. And there are focus and efforts in trying to use or measure these triglyceride-rich lipoproteins a little bit better. Now, this was a nice paper from the European Society of Cardiology where they looked at approaches in trying to do this measurement of triglyceride-rich lipoprotein, and the pros and the cons with this. Obviously, non-HDL cholesterol can give you some amount of that, but you can actually measure the remnant particle or, the triglycerides in the different lipoproteins. All of those are there. And there are other emerging therapies which include measuring total ApoB, because right now when we do ApoB, it's typically ApoB 100, but what about ApoB 100 plus ApoB 48? Getting all of them together, and should we start looking at a total ApoB? So there are ways or approaches looking at these things as we move forward, and hopefully this will, help further reduce our residual risk as far as that goes. Now, we took LDL cholesterol as a construct to look at traditional risk factors. We saw how we're not doing a perfect job with what we have, that we could do a better job, and what we may be able to do, newer or novel approaches in looking at further enhancing the risk. What about novel risk factors? And there are several of them. I think in a given year, if you look at risk factors and novel factors, you may find about 500 papers talking about association with cardiovascular disease. The thing is, one thing you want to remember is the difference between a risk factor and a risk marker. A risk factor is in the pathway of disease, while risk marker just marks the disease. The other thing you also want to think about is whether the risk factor can improve risk prediction. You can have something which is a risk factor, but it may not necessarily better predict risk, right? Both can be true. So in that situation, they may be a target of therapy. They may just not do a better job at risk prediction itself. But identifying novel risk factors will help. And there are several approaches in that. Obviously, inflammation is front and center with that. We all know inflammation is association with cardiovascular disease. We know that atherogenesis or atherosclerosis is an inflammatory disease. We have leukocyte adhesion, which happens from the inflammation. Then there's transmigration. It sets up shop in the subintimal spaces, forms, your cholesterol plaque, and when that cholesterol plaque ruptures, you end up having thrombosis and an event, and inflammation is in front and center of all of these processes. And as a result, there has been a lot of focus on what it means. I mean, even simple observations, you have gingivitis, you have a higher risk of cardiovascular disease. You have a pneumonia, you have a higher risk of NMI. You have inflammatory conditions, rheumatoid arthritis, et cetera, you have a higher risk of cardiovascular events. So all of these were pointing towards inflammation being associated with cardiovascular disease. And in fact, a lot of people, and Dr. Ritker specifically has worked a lot on this and shown very nicely and elegantly how increases in your C-reactive protein are associated with, increased incidence of cardiovascular disease. And as you know, C-reactive protein is a non-specific marker of, inflammation. Now, there have been studies that have looked at C-reactive protein as well. And here in a statin-based study, what you see is in patients treated with statins, the ones who had underlying inflammation had better bang for the buck, further risk reduction when you were treated with a statin as opposed to those who were not. So this also, you've seen of these dual goals, right? LDL cholesterol and lower C-reactive protein. And you see that individuals with high LDL cholesterol and high C-reactive protein do the worst. The ones with both of them, LDL under 70 and C-reactive protein less than 2, do the best. If you had one of them, them discordant, then you do kind of in between. Now you might say, hey, how frequent is this and how, big of a problem is it? And if you look at this, if you look at the actual how common this residual risk is, you can see here in neither, which is both hsCRP less than 2 and LDL cholesterol less than 70, which is your purple bar, it's only about 30-40% of the individuals. The remaining individuals have either one of them or both of them. Both of them being elevated is there in your yellowish thing, which is about 15% of the individuals, and 13% have, LDL cholesterol that's elevated, while 33% have C-reactive protein that's elevated. The point being, almost 50% of the individuals will have the C-reactive protein elevated, and these are individuals who might benefit from therapy if you're able to find good therapies as in, for targeting inflammation. LPA has been front and center of this. We know LPA is a risk factor for several things, including cardiovascular disease. And there are obviously several approaches that are being taken. We know higher LPA is associated with higher risk of events. And there are several approaches being taken to treat LPA and trying to see if that further reduces risk. LPA in combination with inflammation also increases the risk. And as you can see here, if you have both of them elevated, you have a higher risk. And that's, again, combining with C-reactive protein, showing that patient with a higher risk. So if you look at residual risk, there are several therapies and approaches that are being developed, targeting triglyceride-rich lipoproteins, targeting LPA and inflammation. All of these things are being focused on, and these are kind of the cholesterol inflammation spectrum, if you would. Now, overall, if you look at other things such as societal causes of residual risk, I jokingly refer to atherosclerosis as a lifetime achievement award. If you live long enough, all of us are going to get it, right? This is a process that starts at a young age, and slowly over the course of time, we start recognizing it. In this wonderful study, the PESA study, which looked at ultrasound and CT scans looking at identifying subclinical atherosclerosis, Dr. Fuster and group showed us that by the age of 40 to 45, a good majority of the individuals, almost 50%, will have some plaque somewhere. Okay, the iliofemoral seems to be the earliest plaque source, but again, you'll have some plaque at some place. They've also shown with elegant data that if your LDL cholesterol is low, the risk of you having it is the least. In other words, LDL cholesterol is in the 50s or so. So having a good health will have a reduction in risk of cardiovascular disease. Now, this is what's considered, simple 7, essential 8, however you want to call it, but things that are considered to be ideal health. Smoking, never doing it, or quit long time ago, a good BMI, physical activity about 150 minutes a week, good diet, total cholesterol less than 200, blood pressure less than 120 over 80, fasting glucose less than 100. You think about this and think about how many of you have all of this perfect. Okay, you probably thought about it. And let's see, what percentage of the US population do you think have all of this perfect? Okay, as you think about it, this analysis was done in the ARIC study, and in the middle-aged population, they found that ideal health metrics and all of them were there in 0.1% of the population, 1 in 1,000 individuals. Now you might say, hey, you know what? Okay, I'm vegetarian, I don't eat fish, so maybe that's why I didn't qualify. Oh, I have everything but one. But look at this, even intermediate health, which is 1 to 7 intermediate metrics, there was only 1 in 5 individuals. The majority of the individuals had at least one poor, health metric as far as that goes. And that's what we're facing with, right? And that's why even though we have advances in medicine, things are not necessarily going as far as, completely our risk reduction is not as much as we have it. So when you think about cholesterol, all of us are in this kind of a marathon, right? We're on this pathway. We have to decide when we get on, what we need, and things like that. And this is something that we have to shape as we go forward. But at a young age, important information, education is important. So that primordial prevention becomes important as far as this goes. So what are the next steps? Obviously, we need methods of better estimating risk, and we continue to work on that. There may be use of biomarkers in imaging. We go a little bit over that. And what is the role of AI, and how can that help us with this? Now, if you want to improve risk scores, we talked about several markers being associated with it. Is there a way for us to improve risk scores and making it flexible? In other words, using the information we have available. And this is what we did, collaborated with some of our European colleagues and looked at risk factors addition of to see how we can modify score 2. And indeed, we looked at several factors, from CAC to ankle brachial index to C-reactive protein to BNP to LPA, albuminuria, all of that. And overall, all of them are associated with risk. And when you add them to the equation, you do better estimate risk. Yes, there are some that are better. For example, here CAC and troponin were better than other ones. And these do increase and improve your C statistic. That's for the risk prediction part of it. And these are ways, once you have this information, you can factor this in and do a better job with it. We've done a similar thing with heart failure. And again, with the advent of AI, you're going to have a lot of machine learning opportunities with it, where the computer can use the information you have available and predict, or better predict your risk and use that information to come up with risk scores. So that's why these kind of data become important in developing, so that we understand where the risk is. And here you can see several risk factors were looked from a heart failure risk prediction point of view. And what they found was several markers were increased, that were associated with risk, and you can do a better job. Again, with ethnicity based, some were more prominent with one versus the other, and things that you can use to help enhance your risk prediction itself. Now, and this is basically how most of these studies are done, where you have a derivation cohort where you build your analysis or prediction model, and then you validate it in that. And that's basically what was done here, showing that these markers can all be used to help us better estimate risk. Now, obviously, there are also data that are using other things. For example, where you live. What's your social environment? What's your built environment? What's your natural environment? What's your genetic exposure, right? There are so many things that you can factor in, and all of these things will help us better build a story on an individual level as to what that risk may be. And as we do this and we better identify risk, we may be able to target those individuals who need more intensive therapy and perhaps others who don't. Because remember, there is a cost to pay every time we want to intensify treatment, be it the true cost, the dollar cost, or also the side effects and things like that. So, societal cost is also there with all of these things. So identifying and becoming smarter will help. And there are ways, or there are approaches that are going on at this point of time trying to look at the same thing. Now, obviously, this is why AHA and ACC have built and started building things like the PREVENT equation, where there's some flexibility. Use the information you have to better derive a risk score, and that's what PREVENT did, which added things, including as you know, the key takeaways were they added things, including they gave you a 10 and a 30-year model of risk, but they added information that was maybe available. For example, again, socioeconomic deprivation, right? So to acknowledge that and try to factor those into being able to build a risk model. If you don't have that, you don't use it, it'll still give you a risk score, but having this may help you better build your risk prediction models. So there's a lot of ways in doing that and helping us identify risk. But on the other hand, the other things we also need to do is remember, why do you care about cholesterol? Why do you care about blood pressure? It's because of the end organ insult with it, right? We, as clinicians, always know we have some patients who have super high cholesterol, they're doing perfectly fine. Super high blood pressure, doing perfectly fine. So better being able to identify those who are not happy, or those whose hearts are not happy with their risk factors, is another approach to taking. And this is where using things like biomarkers and imaging could help. Now, we know that the hypertension guidelines, the last set, and there's a new set that just came out. I haven't yet updated the slides on that one. But overall, what they did show was that if you had blood pressure that was like, 130 to 139 and things like that, right now the recommendation is to estimate your 10-year risk. Why? Because if you have, if you look at every stage of hypertension management, if your risk, the relative risk reduction is similar, as you can see here, but if your underlying risk is higher, your absolute risk reduction is more. In other words, you have more bang for the buck and lesser number needed to treat. Okay, if you look at the left panel with the red bars, the relative risk reduction, if your score is less than 10%, 11 to 15, and 15 to 21, it's almost identical, right? About 15 to 20%. But if you start looking at the absolute risk reduction, the higher your underlying risk is, your absolute risk reduction is more. And if your absolute risk reduction is more, what does that mean? You have lesser number needed to treat to get that benefit. So you're identifying the highest risk individual who could benefit from that. Now, and this is the number needed to treat, like we talked about. You can see here how if your underlying risk goes up, your number needed to treat actually starts coming down. Now, overall, the one thing we do is if you take any of these risk scores, when we factor in blood pressure, we take the blood pressure that's provided to us in the clinic, right? Now, remember, all clinics tend to be busy, so that's quick in and out. So our nurses or CNAs are taking it. They try to do a good job with a few minutes of wait and rest and things like that, but it's not perfect. Now, here is a study in the ADDIC study where we looked at it, where we had multiple blood pressures in the same day, okay? And this is an idealized research setting, right? We found that there was a good amount of blood pressure variability through the day. And more importantly, when we calculated the 10-year risk, on that same day, there were individuals who could go from low to high risk just because their blood pressure went from 120 to 180 or so on and so forth. The point being, the blood pressure is something that changes, right? My blood pressure would have changed from the beginning of the talk to now, and so would yours have, right? So when this changes, we are capturing one snapshot, using that in a risk equation and taking that to be, that's the blood pressure we use for the risk estimation. So the question is, can we do a better job with that? And this is what we tried to see. And, this is the things that we have seen. And if you look at, cholesterol reduction, again, the same kind of concept. We'll get back to the blood pressure story in a minute. But if cholesterol reduction and 5-year risk of events, again, if your underlying risk is higher, okay, you have more bang for the buck. If your underlying risk is, as you can see here, you go on the z-axis, as your underlying risk goes up, you have more bang for the buck when you're lowering the cholesterol the same amount. If your underlying risk is lower, the bang for the buck of lowering the cholesterol is not the same. There is still same relative risk reduction, but the absolute risk is lower. So understanding this underlying risk is going to be very important in trying to take care of that. Here, is a study that looked at coronary calcium score and how your blood pressure management could change depending on your underlying calcium score. Now, on the y-axis here is the number needed to treat to prevent CVD or heart failure. And if you look at those bars, the bars are, the solid square is a calcium score of 1 to 100. That's in the middle. On the top, you have the ones with a calcium score of 0, and the bottom, you have calcium scores above 100. Okay. In these individuals, if your calcium score is higher, you need a lot fewer individuals to treat to get to what you wanted to do across every risk spectrum. So again, the higher the risk, if you're able to identify it, in this case with coronary calcium score, you were able to get a benefit with that. And based on this, they came up with an algorithm based on calcium score testing about who you may want to intensively treat, for hypertension, and who, you can maybe wait and watch. But these are not randomized controlled trials. These are observational. So you have to take it with a caveat with that. Now, we've looked at that similarly with other things such as biomarkers. We've talked about the difference between risk markers and risk factors. And when we looked at biomarkers, there are several of them that you can consider. Let's take troponin and BNP as a potential example. We talked about how the hypertension, there's variation and things like that, right? So in this study, in the ARIC study, we looked at high sensitivity troponin and categorized individuals based on their blood pressure. We categorized the individuals with, a systolic blood pressure less than 120, 120 to 139, greater than 140, 149, basically across the different categories that you would. Now, across each of these categories, there were individuals with high troponin and individuals with undetectable troponin. Again, these are not patients coming to the hospital with chest pain. They just came for a routine appointment, follow up on a research study. Now, here you see on the x-axis, the troponin T measures, less than 3 and going all the way up to greater than 14. This is high sensitivity troponin. On the y-axis, you're looking at the hazard ratio, and then the z-axis, you're looking at systolic blood pressures. What was impressive is if your troponins were less than 3, undetectable, you can see across the board, even from 120 to 150, 159, your risk was not, it was there, but it was not super high. Overall blood pressure does predict risk in each of these categories. The higher the blood pressure, the worse you do. But you can see that the step up is not that much. But on the other hand, if you look as the troponin goes up, your event rates start going up. In fact, if you were an individual with a systolic blood pressure 150 to 159, and you had an undetectable troponin, your incident or your hazards for the event were lower than somebody with a systolic blood pressure 120 to 129 whose troponin was elevated. So this is telling you potentially that the troponin is identifying individuals whose heart is not happy. And maybe these are the individuals, potentially you could understand and say, hey, maybe they need more intensive treatment. Again, identifying that residual risk and trying to be more intensive as far as that goes. We then looked at it with NT-proBNP, and a similar story emerged. When we looked at NT-proBNP with that, again, over these 9,000 participants, if your NT-proBNP was high, over 300, they did worse than somebody with an NT-proBNP was less than 125. Now, you remember, at this point in time, based on data such as this, both troponin, high-sensitivity troponin and NT-proBNP have been included in guidelines to identify stage B heart failure, but they're not yet included in identifying atherosclerotic cardiovascular disease risk. And I think, if you look at data such as this, and here you see the numbers needed to treat, if your systolic blood pressure was higher and if you had a lower NT-proBNP, the number needed to treat again would be on the low, on the higher side because your NT-proBNP was lower. So across the board, as your NT-proBNP is lower, you need more people to treat to get the benefit. As your NT-proBNP is higher, you need lesser individuals to get, to treat to get that benefit. So, but like I said, it's also, with cardiovascular disease, and these are the numbers needed to treat, as you can see across the board, the same thing that we talked about. So heart failure, people use troponin and NT-proBNP, but also it's a very good marker of atherosclerotic cardiovascular disease risk. And this is why we made this argument, which is, just recently published, about why we think troponin and BNP should be considered to be risk enhancers at this point of time, helping us identify that residual risk and, the characteristics of this. So the next thing that we have to think about is how AI can help. We already delved a little bit into it, how it can make a better way of helping us predict risk, right? And that's something that AI could play a big role using the information that we have. Now, remember, already there's some elegant studies that are looking at things like just, looking at calcium in a CT scan. AI can help us identify it on routine CT scans. And if you start notifying physicians, this elegant work from Stanford looked at, association of coronary calcium score, detected by routine ungated CT scans, which were communicated to their primary care providers. They took individuals, about 5,678 individuals. And what they did was, if you had any calcium that was identified in ungated studies in the coronaries, they went and they first found and described that you had an increased risk of events. All-cause mortality, death, MI, stroke, all of those, there were an increased risk of events. And then when they started notifying the physician and the provider, what that ended up happening was they started treating them more intensively. Right? There was more intensive treatment with that. You can see how AI could easily run through these CT scans, identify it, and send a message to our providers, our physician, primary care providers, cardiologists. And when that happens, and then the patient is aware too, maybe there's a little bit more chance of having that discussion of whether they need to be, any of their risk factors need to be modified. So this is a way of getting at the residual risk with, the help of AI. Now, obviously, there are other things that are going to come up. There are going to be different variable technologies. There are going to be different ways in which AI is going to continue to contribute by identifying, again, white coat hypertension, blood pressure at home, these kind of markers. And then there are other things that the AI will see that we won't be able to see. And maybe they start identifying patterns and helping us identify those higher risk individuals whom we can actually treat and make better. So these are all approaches that will evolve, and this will all hopefully help us, reduce our risk of residual risk. Now, obviously, AI can also do a good job with medication development, because not only can it help you identify risk, it can also help us identify targets, right? It helps you identify a potential issue, it helps you identify a potential target, and helps us, develop medications or something to go at it. And this is already going on, but they're starting to identify potential targets for us and helping us identify newer therapies that could come out. So it can also help us with trial design. You can identify patients so much more easier. You can get those studies being done faster, and all of these things can help over drug discovery, drug toxicity prediction, design. All of these can be helped with AI as we move forward. So, in conclusion, overall, if you think about residual risk as a concept, it is something we inherently understand and know. In other words, we know that, although we've made strides and we made things better, cardiovascular disease remains the #1 killer. So we know that there is that risk that's there. The question is, how do we identify it? What can we do? And how do we go forward? Now, from our end, at this point of time, what's actionable today? We can make sure the known risk factors, we've had a good approach to them, we have a good understanding of them, and we have good care towards them, and we're monitoring and going from there. We have to use these risk enhancers. We have to use those other things which we know increase the risk but are not factored in risk equations, and help guide and steer our patients, or have that discussion with them. From a society level, we do need, a good focus on early health education and early, taking care of these risk factors and primordial prevention, and society recognizing the importance of this in their long-term outcomes in cardiovascular disease, and, helping with that. Of course, we're going to discover newer risk factors, and exciting therapies are coming out of known risk factors, for example, LPA or higher triglycerides. A lot of focus on these kind of things, inflammation. So as we get this, we will chip away at that residual risk, but that some will remain, and this is where we are going forward. With that, I'll stop and see, let's have a discussion on what questions you may have about residual risk and overall risk management in these. Thank you so much.
Hi, thank you, Dr. Nambi. That was really great, really talking about how we identify residual risk and then ways to lower it. So thank you for that. We're going to have some questions from our audience, and we've got a couple here. So I'd ask anyone else that's out there, if you have questions, continue to bring them in, and we'll answer them as we go through. So the first question I'd like to ask is, can you comment on the role of physiologic tests like an EndoPad or some other way to assess endothelial function assessment in the assessment of residual cardiovascular risk?
I think all of these tests can augment our information that we have available already. Now, typically, when you think about persons with established risk factors, persons with established heart disease and things like that, invariably, they have some amount of endothelial dysfunction, but there is a spectrum of it. And this is where, tests such as EndoPad and other physiologic tests can help. Now, we know that obviously if it's worse, then your risk is higher. In that much, it can help. And it is providing a form of end organ injury, if you would. So as more data emerges with the association with endothelial dysfunction with outcomes in these conditions, I think you'll be able to incorporate more and more of these testing to help us identify, again, to me, I think the biggest thing is in each risk factor, in each condition, there is a spectrum. Some people have a lot more damage and some people have, a little less damage. And these testing, if they can help you identify that, will help us move forward.
Okay, excellent. Next question is moving over to lipids. We sometimes see ApoB at goal, but not HDL-C. And that's driven by remnant cholesterol with hypertriglycerides as a surrogate. Other than augmenting lipid-lowering therapy and icosapent ethyl, what else can be done, and does it matter?
Yeah, so two questions in there. What can be done and does it matter, right? So the thing is, if you look at even the study we discussed during the course of this talk, generally ApoB tends to be a better predictor, and then say even non-HDL cholesterol as far as outcomes go, mortality, heart attack, and all that go. Both of them are overall better predictors than LDL cholesterol, and in general, ApoB, if you comparatively, seem to better predict risk compared to non-HDL cholesterol. Remember, every atherogenic particle has some ApoB on it, and that's why they're more, the better predictor, if you would, as far as that goes. Now, if you find a discordance, generally I would trust the ApoB a little bit more for the reasons I talked about. And what can you do at this point in time? It's again going back to the basics, focusing on getting your cholesterol, LDL cholesterol to range. And as was mentioned, icosapent ethyl is also there. With the caveat, there was some controversy about the study and things like that. We always have to keep that in the back of our mind. But, those things can help us reduce our risk. Now, what can be done? Why is it important? No, I think it is, because as we go, even when we see LDL cholesterol, we're trying to decide what the ultimate goal or target is. Should it be less than 70? Should it be less than 55? Should you go down to 30? And these kind of things, especially if there's discordance, can help perhaps guide you. Now, granted, there's not outcome, clinical studies-based evidence, but there's some observational data to say these are higher risk individuals. And so that's where having that discussion with your patient can help you, move forward to see if you can identify and at least reduce the residual risk associated with cholesterol to an extent.
Okay, excellent. Then another question just came in. How do you counsel patients who present to your clinic with advanced testing, such as cholesterol balance tests, lipoprotein fraction size particles, homocysteine? I think really what they're asking is things you may not have ordered, but they already have in hand.
Right. I mean, I think I basically tell them, listen, this is all useful information to tell us where the risk is, but it may not be actionable. In other words, based on this, I do not know how I would change your treatment. Our studies are grounded on using total cholesterol, your non-HDL cholesterol, maybe ApoB, in trying to treat our patients. So this is all useful information that tells us what your risk is. And then I also discuss with them some of these things. For example, we know that statins reduce the risk, of cardiovascular disease, but yet they cause smaller, lipoprotein particles or smaller LDL particles. So I tell them there are those discrepancies, so I cannot hang my hat on that. Ultimately, what, the proof is in the pudding. Statins reduce risk. That's what we should be focused on. These are helpful information. It may not necessarily change what I want to do, but if the patient is more of a numbers kind of patient, wants to know what it is and things like that, I say, hey, it's useful information that you can have, but it won't make a difference. It won't change our approach, at least at this point in time.
I think that's a really great response. I know in my practice, I'm seeing a lot more people coming in with sort of adjunctive testing as it becomes available commercially. And they are very excited about it. So I think using that diplomatic strategy you just mentioned is great.
I like to tell them that, hey, it's good information. I'm not, there is good data saying this is information, and, pathophysiologically it makes sense. But what can we not do with the information is what the thing is. So I say, the non-HDL cholesterol is a good surrogate for some of those things. The lipoprotein particle number is helpful, but can we modulate it and change it a little bit? We don't have clinical evidence to say, using that or using that as a target. That doesn't exist at this point in time. So we wouldn't do too much different at this point.
Excellent. All right. So next question, do you see a role for CCTA or CTA with plaque analysis in the asymptomatic primary prevention population?
So do I see a role? I mean, obviously having information on plaque is, vital. That tells you what's going on at the level of the vessel. The issue is the cost and the radiation risk. As the radiation risk comes down, and if it comes down to such a small amount that, we should, and the cost and the throughput's going to be there, sure, that may be a role. But at this point of time, I think, especially again, you have to decide on which age group and where you're using it. If you're using it in a 20 or a 25-year-old, there's going to be almost no value. As we grow older, it's going to come into value. And I think that, and as we develop more therapies, right? So as we develop more therapies where we are going for a higher yield or, there's cost to it, there's also benefit of the therapy comes in. Who do you want to apportion it? These things could have a role in the future. At this point of time, yes, a CCTA trumps calcium score as far as, what its predictive value and, thing is, but the cost and also the radiation risk at this point of time, you cannot recommend it in all the individuals, but if the information is available, it does help. At this point of time, I don't see a routine role. Down the line, as our throughput improves, as our radiation risk goes down, as our contrast-based risk goes down, all of these things go down, we may see an enhancing or an expanding role.
Excellent. And I think we'll learn more about sort of what does plaque composition analysis tell us, right? Can we treat some of these things and what works, and are we lowering event rates?
Exactly. To an extent, our diagnostics are going a lot far faster ahead than the therapeutics. So ultimately, there has to be a little catch up between the two because this information is all very helpful. But the question is it actionable? And that's the question I ask myself because, remember, we're having a cost to the patient, to the society doing these extra tests, and also cost not only from a financial aspect, but also, potential risk. You find something else, what do you do about it? All of those things come in. So these are things that we have to keep in the back of our mind.
Excellent. Okay, so we got a question about AI. Do you have concerns about the misuse of AI as there is a risk with personally identifiable info until AI is better regulated?
Yeah, I mean, this is a hot area. It's an area that has to have information. I saw one interesting study actually at the ASPC a year or two ago, where the way the question was asked gives you the answer. Like, in other words, if you start asking a question about statins and you have a negative frame to the question, the answers it gives you are more negative. If, on the other hand, you ask the question in a positive frame of mind, the answers it gives you is positive. So there's lots of work to be done with AI, but remember, AI is something that learns, and as it learns, it gets better. So hopefully, as time moves on, it'll be more of a friend. At this point of time, it is not, obviously the question asked here is personal health information, and that has to be regulated. It's very important. In fact, there are, AI software tools right now where you can feed in your images and it compares it to, tens of thousands of images across the board and gives you information based on that. So obviously, what kind of personal health information is lost or can be lost is important. I am not a expert on that as far as this thing goes, but it is something that people should watch. And, absolutely, point is well taken.
Excellent. All right. So if we're talking about advanced testing, do patients have to pay for these tests out of pocket? And do you feel strongly about the cost-benefit ratio?
Yeah, to me, I always feel, that is important. That's why if a patient comes and asks me, should I get an advanced test? I would tell him or her that I don't think I'll change my recommendation based on what information I get. So you have to make sure that, it's covered for you or what the cost is. Some of them, it's part of the executive health physical. So they get the information. I'm happy to use that information and, in my decision. But I never recommend it on a routine basis, telling, please go get it and come and I want this because of the reasons that you mentioned. Now, as far as the cost goes, again, it varies from insurance company to insurance company. Sometimes they get it in executive physicals or, the company provides for them. So those kind of things, if that information comes, it's helpful, it's great. But again, I always warn my patients up front saying, I will not change my decision based on this. What guides me, or, as far as my therapy goes, is the information we already have. But if you get it, and just be sure that your insurance covers it. If they don't, make sure you are able to pay for it. So I'm upfront with them, and I do have that discussion with them.
Excellent. I'll ask you another question, more probably a thought-provoking question. But if a primary prevention patient comes in to see you, and all the risk factors are pretty well controlled, but has an elevated inflammatory marker, C-reactive protein. First of all, would you check that if it wasn't checked? And second of all, does it alter what you would recommend to the patient?
Yeah, so that is a interesting question. I'll answer this question and then I'll go back to your, the structure or the framework of the question. So to me, I think the question is, why was that inflammatory marker checked in the first place? Because was it checked in the setting of an infection or something else that was going on that was checked? Obviously, if that's the case, we want to repeat it, and always in an isolated elevation inflammatory marker, I look for other causes. Sometimes maybe they have an autoimmune condition, maybe something else is going on. So you got to go through that history in a little bit more detailed fashion. And very often, invariably, I would repeat it. Now, if they have an inflammatory milieu going on, obviously it increases their risk. So in that case, it's a patient-physician discussion. I look for atherosclerosis. Maybe I would get a calcium score, or maybe I would get something to see what's going on. Now, would I treat them? It again depends on what normal is, right? So we talked about the risk factors being controlled. I think, wrote an editorial in Jack some point of time where I said, we use these terms normal and things like that very often, but what is normal? What is a normal LDL cholesterol? I honestly don't know, because we know is we know there are thresholds where we would recommend treatment depending on age and underlying risk, but I don't know what the normal would be. Is the normal 50 because that's what around where we're born with, 50 milligram per deciliter? Or is it should be 30s or 40s or 60s? It may be in that some, and there's data saying that the least amount of plaque development was when your LDL cholesterol was in the 50s or so, right? So this is one advice I always give primary care providers, saying, when you talk to your patients about when their cholesterol panel comes back or something like that, don't tell them it's normal, use the word normal, but just tell them there's nothing to do, or right now I wouldn't treat it. I would say it's not optimal, but I wouldn't treat it at this point in time. I've had so many conversations with patients who would come in and say they would have had a heart attack, and then they would tell me, just 1 week ago, I had my meeting with my primary care provider, and I was told my cholesterol is normal. Now all of a sudden you want me to treat this cholesterol. What's going on? So that's why having that word normal is a very relative term. In my mind. Even if you look at blood pressure, we know mercury, your risk starts going up. So, but we don't necessarily our patients know about that.
Excellent. All right, I think we've got time for another question. Let's see. Lipoprotein little a and high sensitivity CRP are such powerful markers of residual risk, yet cardiologists are slow to adopt testing. We often get pushback, such as there's nothing we can do about that. LDL is less than 55. So a play on sort of what we were just discussing. What are your thoughts on encouraging more testing? And then what would you do for it, I guess, is the question.
Should get one LPA level checked at their lifetime. A lot of societies are coming and confluencing around this, so this will help. As far as HSCRP, again, we know from Dr. Ridker's work and a lot of work similar to that there is that residual inflammatory risk, and we know statins can help with that. Now, whether there's going to be a new therapy, cold therapy that comes on, we'll have to wait and watch. So I do think it's useful. I do think it's important to help identify that residual risk, because maybe that will help our patients also follow the recommendations for their traditional risk factor management, even if there's nothing actionable. Maybe if they know they're at elevated risk, maybe they're more likely to take care of it. Or maybe if they're overweight or obese, and that's one of the things that's driving the C-reactive protein, maybe they will be more attuned to trying to get that part of it done. So I think it's helpful to get it done. I think it's useful to discuss it. And LPA is going, it's more and more guidelines are coming up with the recommendation at least to get it done once. Once it starts getting covered by payers and stuff like that, I think you'll see an automatic, more people doing the testing.
Excellent. And I think you're right. I think really setting that baseline for we can measure these numbers and they're elevated, but really we're going to focus on the things that we know lower risk and lower these as well. Okay, so maybe one last question. GLP-1s, obviously GLP-1 receptor agonists, we know reduce high sensitivity CRP, and we know from the SELECT trial that CV outcomes support use in secondary prevention. How often are you using GLP-1s in your management of residual risk?
Yeah, so the thing is, it's an emerging field. Obviously, the problem is the cost. It's very difficult to get coverage on those kind of things. Obviously, GLP-1 agonists have done a wonderful job, as pretty much any outcome you take, they're showing benefits. And as the cost and affordability gets more, I think we can help. I think it'll be a big, tool in combating residual risk. But I also showed you data about how even despite GLP-1 agonists, there is still a residual risk even beyond that. So I think we have more work to do. GLP-1 is certainly going to fill in some part of that space. The issue right now is more the cost consideration and things like that, what can and what is and what's not covered.
Excellent. Well, I think that we've had a lot of great questions. We learned a lot of information tonight. And unless you have further comments, Dr. Nambi, I think we will go ahead and close out this CardioCore lecture.
No, thank you for your invite, and thank you for allowing me to share some thoughts on residual risk. Appreciate the time, and if there are any other questions, please feel free to contact me. Thank you very much.
Excellent. And thank all of you for joining tonight, and catch us again next month with our next topic.